I have a few other slides. I'm going to talk about Delta, and I have a few other slides just to maybe update a couple points about vaccination and risk benefit if there's time. And I'm not sure how much time you have slotted for all the different things, but you can kind of cut me off if you need to after I'm done with Delta, Tim. I'll have about maybe 6 more slides beyond that. So the CDC recognizes what they call variants of concern and variants of interest. So as the virus replicates in people, it can be somewhat sloppy in the way it replicates itself. And so that means it introduces various mutations. It doesn't make perfect copies of itself when it replicates. And sometimes those mutations are advantageous, and sometimes they don't help the virus at all. Variants of concern are mutations that lead to a new strain, if you will, that are of concern because they are either more infectious, or they may be better able to evade the immune system from prior vaccination or prior infection, or they may be more virulent. And so right now we have 4 variants of concern: alpha, beta, gamma, and delta, and a number of other variants of interest that as such, so far, we don't see any of those more worrisome aspects of them, although that remains to be seen. So the Delta is the one that's the sort of newest kid on the block, and the one that has raised the most concern lately, and so I'll touch upon that. The World Health Organization is calling Delta the fastest and the fittest, and indeed that seems to be the case. When it was introduced into India, we saw it sweep through that country very rapidly with these sort of horrific scenes of so many people overwhelming their healthcare system and dying that they weren't even able to manage the morgue capacity there, and they were making these outdoor makeshift crematoriums to handle the dying. And as it was introduced into the UK, you can see it kind of first started to appear in late April, early May. And by mid-May, early to mid-May, it had become the predominant strain and has really kind of introduced a new surge or a new wave in the UK. And I'll point that out a little more distinctly here. Both the UK and Israel are both seeing significant rises, a third or fourth wave, depending on how you count that. And these are 2 of the most vaccinated countries in the world. The UK has about 68% of all people having at least 1 dose of a vaccine. Israel about the same at 66%. And despite those very good vaccination rates, they are seeing resurgent cases, and several of the places in Europe and in Israel now are contending with reinstitution of masking mandates and lockdowns, etc. And these are predominantly occurring in the unvaccinated, overwhelmingly, these cases. If you kind of compare this to the most recent variant, the alpha variant, that variant was about, depending on the studies, 43 to 90% more transmissible or more contagious than the original strain. Delta is being compared to alpha, and delta is about 65% more transmissible than alpha. So that puts it somewhere around double or more in its ability to transmit. We previously heard reproductive numbers. That's the number of new infections typically generated by an index case, with the original strain being somewhere around maybe 2.5, 3.5 on the high end. Experts are placing Delta to be somewhere around 6 to 7 reproductive numbers, so much more contagious. And this is a little bit of a busy slide, but this was out of the UK, and it's pointing out that in the gray bars here with an earlier strain, which would have been April through early May, would have been predominantly alpha. You can see the distribution by age group. It's kind of across the board, maybe a bit more in the 25 to 34-year-olds. But with Delta, it's much more in the young. Here you see 5 to 12, 13 to 7, 18 to 24. It's selectively affecting the young much more frequently. And this, again, sort of a busy slide. This is looking at the UK data, but deaths and hospitalizations, kind of pre-vaccination rollout, post-vaccination rollout, and you can see deaths and hospitalizations overall falling really well until very recently. And if you break that down between those who are younger than 65 versus those who are older than 65, it's the under 65 crowd that is driving the new rise in hospitalizations and a new bump up or rise in deaths. So what do we have any data to suggest Delta is more virulent, meaning more likely to land you in the hospital or more likely to kill you? I'd say the jury on that is still out, but there are some concerning trends. So just a study that came out of Scotland very recently was they noted that Delta had become the dominant strain by about May 19th, and they looked at outcomes from April 1st to May 28th, so sort of prior to Delta. When Delta had just started to come in, 39% of the cases were Delta in this time period. They saw a greater proportion, as I've kind of already mentioned, of Delta being seen in younger age groups, like even the 5 to 9-year-old age group, and oddly enough, in more affluent people. The Pfizer vaccine in Scotland appeared to be 92% effective in non-Delta cases, dropping down to about 79% effective against Delta. But most notable to me from this study was that Delta cases appeared to have an 85% increased likelihood to put that person in the hospital. If we look here in the US, Delta has now become the dominant strain. I think Jenny showed a similar slide here. It now accounts for, in the US, 83% of all sequenced cases. And there seems to be a concentration of that a little bit higher in the Midwest and West. So I think we can count on this being our dominant strain. If it's not already within a matter of a few very short weeks, it will be the dominant strain in the United States. And getting back to that, is it more virulent? This is data from North Dakota of percent of cases hospitalized in 20 to 29-year-olds. So young, typically, a healthier group. And previously that ranged somewhere between 0.4 to at the very beginning, maybe 1.4, 1.5%. And now with very recently, and we don't know if this is Delta or not, but I have my suspicions, significantly higher percent of these 20 to 29-year-olds being hospitalized. I will qualify that by, I was having a nice dialogue over this question with a good friend of mine who's the director of disease control at Oregon Public Health. And he thinks this may be in part due to testing artifact. He sent me a graph of their data on percent of people being hospitalized, and they know that they have Delta now starting to appear quite significantly in Oregon. And hospitalizations did indeed go up. But he also notes that testing has gone way down. So this part of this, higher hospitalization, or maybe we see even deaths, may be due to we have a lower denominator, meaning we're not testing as many of the less sick people, where we were testing kind of anybody and everybody. Here, not that long ago, testing has dropped way off in most of the United States. So some of this rise in hospitalization might be an artifact. I will say, though, I tend to think there's something there, that it's real. And this is a study that just came out of China, and at least gives us some indication why it may be more infectious. And I would say gives another plausible reason why it might be more virulent. They're finding that Delta variant cases are yielding about 1,000 times higher viral load in the oral pharynx than the original variant. This is cycle thresholds, and this is sort of flipped. You have to kind of reverse your mind. Cycle thresholds means how many times do you have to cycle it through the PCR machine to get a positive test. The lower the cycle threshold means there's more virus. You didn't have to cycle it as long. So with the Delta variant, they didn't have to cycle it nearly as long as they did with the original virus, meaning much higher viral load with Delta. And they also found that when you sort of look at what they called a very high viral load, which is highly likely to be infectious, at the very first positive test, they found the wild type in their prior experience. They found about 19% of them had a very high viral load right at the outset on the first positive test, compared to 81% with their Delta cases having a very high viral load right at the onset, meaning likely much more contagious right at the beginning. the time to positivity of testing has shortened with Delta. So on average, it was about 6 days with the prior wild type. That's down to about 4 days from exposure to test positivity. And, Jenny had mentioned we didn't have a lot of real world efficacy on vaccines against the Delta, but we're starting to get some from other countries mostly. So this is looking at vaccine efficacy against symptomatic infection in England, Scotland, Israel, and Canada. I'll maybe just focus on the Pfizer vaccine, which is what we use here in the US. Not a lot of data on Moderna. But you can see in England, efficacy dropped a little bit. Scotland, maybe a little bit more, down to that 80%. Israel looked the worst, down to about 62, 63%. Canada, not seeing much of a drop. So it's a little bit all over. But still pretty good. But I think more importantly, when they look at hospitalizations, I don't have that written on here. This is hospitalization and death on the right here. I should have put that on the graph. It still looks quite good. In England and Israel, even their AstraZeneca vaccines, which typically have the vector vaccines, haven't been quite as good as the mRNA vaccines against hospitalization and death. Essentially, no statistically significant drop in efficacy, which I think is encouraging. Even here in with the dashed lines mean one dose. So in Canada, they've got some one dose data showing pretty good efficacy against hospitalization and death. So kind of summarizing some of this is that, Delta appears to spread a lot faster and to more people. It appears to be affecting young people more. I shouldn't say it's definitively more. I think it may be more likely to put you in the hospital. Again, that 85% higher likelihood in Scotland, a little bit higher likelihood in that 20 to 29-year-old group that we saw in North Dakota. I heard on the radio, Minnesota Department of Health reporting almost double the rate increase in hospitalization rates compared with their older strains. Again, I don't know if that's true increased virulence or an artifact of lowered testing. I do think, and I've heard other experts in this comment on this, that if you haven't been infected or you haven't been vaccinated yet, I think you're highly likely to be infected somewhere maybe by the end of the year or within the next year as Delta and other more infectious strains work their way through the population. Tim, I'll stop there for a second. I can talk a little bit about maybe 6 or 7 other slides on long COVID and some of the risk benefit, but I'll stop if we need to move on.
No, Dr. Carson, please proceed.
Okay, so I think as you're talking to your staff, as you're trying to work your way through this, we've got a lot of folks that just are making, quite frankly, very poor risk-benefit analysis for their own health and for those around them. And so one of the first things I would kind of just mention is it's not just about mortality rates. It's not just about dying. And I can show you, I could show you a lot of data that suggests that the minimization of mortality, like when you hear things like 99.8% of people survive, is really very flawed. But let's just talk about one aspect here, long COVID. We are getting huge numbers. There's like 2, 3, 4 new studies published on this almost every day. This was a systematic review of long COVID from 45 eligible studies, almost 10,000 patients. Majority were inpatient, so bear that in mind that these are people that were sicker. And at least 60 days of follow-up. Some of these are 4, 5, 6, 7 months of follow-up. And so in this review here, 72% of people had at least one or more symptoms at least 2 months out from their COVID. 40% fatigue, 36% short of breath, 28% memory problems, 22% new diagnosis or new problems with anxiety or depression, and about 15% having persistent taste or smell problems. This was outpatients, so milder disease. This was a study looking at prolonged symptoms in a prospective cohort of ambulatory patients, average of 6 months follow-up. And you can see in the over 65-year-old group, over 40% of patients had one or more symptoms. But even in the 18 to 39-year-old group, it's over 25% had one or more ongoing symptoms at 6 months. I mean, that's substantial. This was a study just published today, looking at symptoms at 1 year of follow-up. This was out of Italy, which got bombed by this at the beginning. And here I just plucked out one group, the 18 to 47-year-olds. So again, that sort of, younger, healthier group. Almost 70% had one or more symptoms out a year later. Fatigue in 36%, sleep disorders in a third, muscle and joint pains in a third, cognitive problems in 29%, respiratory problems in 27%. New England Journal just had an editorial saying we are going to be facing the next sort of big national health crisis, which is all the problems from post-COVID symptomatology. So I tell people, yep, you have freedom of choice, and the freedom of choice really is take the vaccine or take the virus, because I do believe everybody's going to be exposed to this at something that haven't had it already or haven't had the vaccine. You're going to be exposed to this sometime in the next 6 to 12 months, and you'll make a choice between taking the virus or taking the vaccine. And let's just pick one of the serious adverse events from vaccination, myocarditis. So myocarditis, and we'll take the sort of at highest risk group here, young males. So this is the breakdown of myocarditis or heart inflammation in cases per million doses. And let me just look at this particular age group, 18 to 24, about 45 to 56, or on average right around 50 cases of myocarditis per million, which has led some people to say, I don't know that I want my adolescent son or my young college son to take this vaccine. Well, this was a study that was done in the Big Ten, in Big Ten athletes. So a big study, almost 1,600 student athletes. So that's that 18 to 24-year-old age group. And they looked at myocarditis from the virus. So what percent of people get myocarditis when you actually look for it? And they did cardiac MRI scanning on all these Big Ten athletes. And it ranged from 0 at a couple of the universities up to a high of about 7.6% of these athletes having evidence of myocarditis after their COVID, which by and large was mild to asymptomatic. On average, 2.3% of Big Ten athletes had myocarditis from the virus. So, yep, you have a choice. And if you're a healthy young male where you're kind of trying to make that choice between the vaccine and the virus, a vaccine has about a 1 out of 20,000 chance that you'll have myocarditis, which overwhelmingly they recover from and have no sequelae or seem to have no problems, versus the virus, which is about, now by that study at least, 1 out of 43. I mean, to not do the vaccine is just very poor risk-benefit analysis, very poor math. I'll take one other example here, blood clots from the J&J vaccine. And we're not giving that much J&J vaccine anymore, but J&J vaccine had overall risk of blood clots in about 1 out of 310,000. Contrast that with you do an overseas flight or a flight more than 4 hours, you got about a 1 out of 5,000 of having deep vein thrombosis. Or if you're a young woman on an oral contraceptive, you got about a 1 out of 2,000 chance per year. I mean, these are risks that people take all the time, but shy away from a vaccine that will prevent much, much, much greater chance of morbidity, hospitalization, mortality because of fear of something like blood clots. So again, this is just bad risk-benefit analysis. So when I see these sort of numbers in our nursing home staff, so thank goodness, as Jenny said, we've got like overall 92.6% of our residents with 2 doses of the vaccine. But having, and I'm just picking the first dose here, having on average 65% of our nursing home staff immunized, frankly, is just unacceptable. To have 35% of our staff still coming into the facilities with the potential to be curing the virus is unacceptable. And if you haven't heard the case of the Kentucky nursing home yet, and I suspect many of you have, but if you haven't, you should pay close attention, especially you who are in leadership positions in your nursing homes. You don't want to be this news story. In this Kentucky nursing home, this was published in Morbidity and Mortality Weekly just about a little over a month ago. An unvaccinated worker came into that nursing home where they had 83 residents, 116 healthcare providers, and they were all offered COVID vaccine previously. 90% of their residents were vaccinated. 52% of their staff were vaccinated, not unlike a whole lot of our facilities here in North Dakota. And on March 1st, one of their staff, an unvaccinated symptomatic staff member who passed their screening tests, came to work carrying a new variant. It wasn't Delta, but it was one of the new variants. And he exposed a large number of the residents and staff to this new variant. What happened? So he came into the facility, and of the unvaccinated residents, which there weren't very many, 6 out of 8 of them became infected. 2 of them died. 4 out of the 6 out of the 8. I'm sorry, 1, 2, 3, 4, 5 out of the 8 had symptoms, and several of them were hospitalized. 4 of them were hospitalized. Of the vaccinated residents, actually a good number of them got infected as well. Now, it was a much better protection than those unvaccinated residents, but he still was able to transmit it to them. And one of them died. And several others were symptomatic. Most were asymptomatic. So the vaccine protected completely a large number of them and led to no symptoms in a good chunk of them who got infected. But it led to symptoms in 5 of those, and 1 of them died. So the overall attack rate in the unvaccinated group of residents was 75%, and the attack rate in the vaccinated residents was 25%. That dropped down to a symptomatic rate of only 8%. So the vaccine efficacy was against hospitalization or death was 94%, 25% death in this unvaccinated group. And among the staff, he infected a good chunk of those that were unvaccinated, and even a handful of staff that were vaccinated. So there was an attack rate in the staff of 30%. 30% from this one individual ended up infected, having to be quarantined, having to be isolated, et cetera, et cetera. So that's a disaster for a nursing home, from one unvaccinated individual bringing in basically with the current conditions we have here in North Dakota.
Thanks very much, Dr. Carson. That's very informative. Appreciate that.